Okay, good afternoon, colleagues. Given the fact that we had agreed on the time and we also did our best to try and arrive on time, I just would like us to get started so that we've got enough time for discussion. I know, you probably have a lot of questions for the team. We may not have all the answers, but we're going to do our best to try and address as many of your concerns. And also, if you've got lessons to share, then we would also appreciate it. Let me start by introducing myself. My name is Mosa Mushabela. I am the Dean and Head of School of Public Health. I'm a family physician by training. I work mostly in public health. A lot of my research is around health systems and policy research. I got involved in this process largely from personal motivation, having come from Singapore, where I was there in the first week of February, and I saw the systems and the responses that they had put in place. And when I came back, because when I was there, they raised their alert level to level 3 because they started to have community transmission at the time that I was there. And I could just see the shift. Their protocols and their systems just kind of activated right then. And you can immediately see how they adapt and they start to do things differently. And for me, that kind of really hit hard because I realized that we're not ready. And so having realized that, but coming back, of course, my first reaction was, look, it's not my business. Someone else will have to worry about that. But when I got back, I had to decide what to do, because when I left Singapore and I having to gone through the airports and Dubai airports and so forth, the question I kept asking myself is, what are the chances that I'm carrying the virus? And if I'm carrying it already, the week that I was arriving, I was going to be in multiple meetings. There were about 4 big meetings that I was going to have to attend and speak at, and then few other smaller meetings. And so I was just asking myself, what is it that I need to do here? I would really, of course, I don't want the disruption that comes with missing all these important meetings I have to do. But at the same time, if there's a chance, even if it's small, that I'm carrying the virus, then what does it mean for all of the people that are going to be sitting in the room? And also, knowing our health system, how are we going to then adequately respond should this virus start to spread? So then at that time, I decided to go under self-quarantine, initially for 1 week. Then for the second week, I went under partial quarantine, where I just kind of went to certain, I went to the office and did certain individual meetings. And at that time, I was already sort of practicing hygiene and being clear that I'm still sort of in the effort to break any possible transmission. But the second week, I still didn't attend meetings. I still didn't attend any sort of group events. Now, there was no reason compelling me to go under self-quarantine. My temperature was fine. That was checked. But when I then started to think about our readiness even more after that personal experience coming out of it, I realized that we've got to start putting measures in place. And so that's when when I was also now tracking, when I went to Singapore, they had 12 cases at the time. Now they've got well over 150, and they are doing well in containing it. Of many countries, they're doing extremely well. And now having seen how it was just kind of expanding all over the world, I was just like, this is a time bomb. And I was much more concerned at the time about what we are doing even in the university. I wasn't even thinking about, say, the rest of the city or the rest of the province. I was just thinking in the university, what is it that we are doing? Then I started engaging in these conversations with people to say, we've got to do something. And so I was given permission to put together a team. And we put together a team from different disciplines: clinical virology and infectious diseases, epidemiology, public health medicine. And we met and we talked. And out of that, we produced a short proposal that we submitted to the university for approval as a potential plan. And that was approved. And I think it was approved on a Monday, announced on a Tuesday, and we basically started working. Our initial approach was largely to focus on emphasizing prevention and breaking any potential transmission, and also managing the people who are traveling from the university to different parts of the world, to say, what is the responsibility of the person? Because what I realized at the time was that at an individual level, you could do things to protect yourself. You might even have better prognosis, but the potential risk of transmission to other people and the population risk as a whole was my biggest concern. So then what I decided to do was to basically start to work with this team and figure out a way of strategies that we could use. And in a space of a week, we did a lot. But what really kind of came to head was on Thursday. We started on the Friday before. On the Thursday, last week, then the case happened. And people were saying, when we started off, people were saying we are overreacting. And when the case happened, people were like, so what do we do? I'm not an expert. We are learning as we go. There's a lot of new information that's coming out constantly, and we are trying to monitor all of these things. But we do feel a sense of duty, given the little kind of lessons we have learned, the little experience that we have, to basically take the time to chat with you and see what is it that we can share. We are concerned, of course, about the students that are placed here as a university, but at the same time, we've got a lot of staff that is here, and the university, and I don't want to speak for the department, but the university has to take a position in terms of what is its responsibility towards the students and the staff. But at the same time, we also have to be clear about what is each one of us responsibility. We all have a part to play. We have to think about that. And we are also then engaging with the department to see how we are going to work together around this. At the moment, of course, people have still been overwhelmed with the identification of the 2 cases that we have. But we need to think about the possibility that this can actually grow into an outbreak. And we need to know what is it that we are going to do and avoid a situation where we panic. So for me, I think I just want to make that clear to everyone that we're not necessarily here as experts. We're just here as a team that has decided to come together to try and figure out a possible strategy and approach to respond. And so far, there's a number of things that we've figured out, things that we've put together, things that I think we've learned from that we can share with colleagues. So I'm going to basically let Richard and Lily to chat to you, and then Eunice is also going to speak a little bit. But for now, let's have a short presentation, and then we can start with a discussion after that. Is that okay? Do you have anything that you would like to say at this point?
Good afternoon, everyone. I'm Richard. I'm an infectious diseases doctor. I am also a researcher. I work at CRISP, which is one of the research centers at UKZN. And I have a bit of training in epidemiology. And that's kind of the reason that I'm part of this team supporting Prof. Moshebela. And Lily, maybe you want to introduce yourself.
Hi, I'm Lily Gaunda. I'm one of the clinical virologists working at Inkosi Albert Lutuli Central Hospital. I'm also joint staff with the University of KwaZulu-Natal.
So I think we have a few slides, but they're really just placeholders just to get some discussion going. And the point of this is just really a bit of information and education about this virus and this disease and what it is and what's the current status of the epidemic. Because the more basic understanding we have, the more we can think about how this impacts on our clinical practice and our public health practice and things. So this is going to work better the more interactive it is. So please just ask questions, stop us as we go, and see where the discussion leads us. So I probably shouldn't stand right in front of the screen. So just so that we're clear about the terms that are being used for this, I'm sure you all know by now that the disease itself is called coronavirus disease, or the shortened term COVID-19, and the virus has been named by this specific group that name viruses, has been called SARS-CoV-2. But you may also be aware that lots of people are not using that term because they don't like it, because it has negative connotations from the SARS epidemic. And so the World Health Organization and others are just calling it the virus responsible for COVID-19. So it's just so that we're aware when we're using these terms what people are saying. Lily is going to tell us a little bit about the virus, about coronaviruses in general, and about this specific virus.
Okay, so coronaviruses in general are responsible, they are found throughout the world and are responsible for the common cold, among other things. But what we found was within the last the last few years, in 2003 we had an emerging coronavirus, which was the SARS virus, which resulted in a specific cluster of disease, cluster of cases, very similar outbreak setting, and that was initiated in China. And again, after that, we found we had another outbreak, and that was MERS. And now we have this virus, which is SARS-CoV-2. All of them belong to the same family of coronaviruses. So there's different spectrum of disease. You see some that cause the common cold, and some that emerge and cause more significant disease. Now, coronaviruses are enveloped viruses, which means that so the differentiation between enveloped versus non-enveloped viruses, the enveloped viruses are more easily destroyed, which is a good thing. So common detergents can destroy it, and something as simple as hand washing with soap and water can destroy it effectively. So the other thing about this coronavirus is that one needs to bear in mind it is something that when we initially found out about this outbreak and its result, maybe in the past with the SARS and with the MERS, we had challenges with diagnostics. But now, with the improvement in diagnostics, it was within that week, one would say, within just a few weeks of that initial diagnosis, those initial cases, the genetic code was already identified for this virus. And so because the genetic code was identified, it was very easy then to produce tests, molecular tests, to specifically identify this virus. The reason why it's called SARS-CoV-2 is just because it belongs to the same, it is related, similarly related to SARS, but it doesn't cause the same spectrum of disease per se as SARS. So it's just within the same family. Also to bear in mind that this virus, shall we go into droplets and all of that now? We'll come back to it. Okay, all right. So do you have any questions about this virus? Okay.
So one of the key things here, I think, is that this is just a virus like all the other coronaviruses. So whenever we have these outbreaks, there's a temptation to think that this bug is something remarkable, that this is a super bug and it's doing something that no other bug has ever done. But the actual virus is just the same as other coronaviruses. It's not got any particular properties, but it's about what the reason that we're so worried about it is because of how easily it's spread and the high mortality that's associated with it. But it's not that the bug has got some incredible property that we've never seen before. From your understanding so far, what is the clinical illness that is caused by this infection? What do you think the classical presentation is going to be of this illness? Flu-like symptoms. And do you want to be more specific? Okay. Anybody think differently or the same? Same? Okay. So, I mean, basically we're correct, but one of the interesting things when we look at the data, and this is data from over 50,000 confirmed cases in China, the striking thing is that the upper respiratory tract symptoms are actually very rare. So the sore throat, runny nose, blocked nose are not common. And the by far the most common presentation is just dry cough and fever. And usually the pattern of illness is that the shortness of breath will come a bit later if the disease progresses. Lily, do you want to just explain a bit why are the upper respiratory tract symptoms not so prominent, and this is more a lower respiratory tract problem?
Okay, so this virus, like all viruses, need to attach to a receptor. Receptor is found on the cell itself. So viruses cannot function outside of a cell. They need to enter a cell via the receptor, which is in essence the doorway. So the receptor that these viruses, these coronaviruses have an affinity to, the receptor is called the ACE2 receptor, which is found in the lower respiratory tract, which is why there is more a tendency to have these symptoms as opposed to upper respiratory tract symptoms.
And that's the same as with the original SARS in 2003. It's the same receptor. So again, this was very quick science where people could hypothesize very quickly maybe this virus uses the same receptor that we know SARS did, and they were able to prove that within a few days or weeks of this epidemic unfolding. So that's just important to know, and like you said, the kind of more systemic things of myalgia, arthralgia, malaise are relatively common, but not all that common. And then things like diarrhea and vomiting are actually very rare, it seems, with this illness.
Can you explain what the implications of this for clinical presentation?
I could, or we could open that question to the audience. What are the implications of this for clinical practice?
I guess it'll be difficult to use those symptoms to exclude the possibility that this infection might not be present. So you will have symptoms of the influenza, which are classic sore throat, runny nose, etc. You cannot say if those symptoms are present, it can't be COVID-19. It could still be COVID-19. Am I answering your question, Demosa?
Yeah, but I think in terms of what the health workers should have a high index of suspicion. What is it that when you are in a clinic, you're obviously thinking about a lot of other things, but then how do you go about the clinical reasoning that helps you to come up with, to have a high index of suspicion when you've got a patient in front of you? I guess that's what I'm speaking to. And that's why I kind of want to not just look at it from the point of view of data, but also get the colleagues to think of it in terms of a clinical setting.
So I guess, again, maybe I'm not understanding completely, but the other thing I would say is that it means that as we're going to come and see, most people have a very mild illness. So it may just be a bit of dry cough. You may not even have the fever. And we have a tendency as medical practitioners to try and make our own mind up about how significant symptoms are. And you see it with TB, that we are told we should screen everybody for cough and fever and night sweats, and that everybody should be tested for TB. And yet we do that, and we still don't test most of the people who have one of the symptoms that we screen for. And part of that is because we think we know better. And I'm not talking about individual people here, I'm talking generally, that sometimes we think, oh, this person's not very unwell. They probably don't have TB. And I think we need to be sure that as this epidemic unfolds, we don't get to a situation where we're trying to make our own risk assessments about how severe things are or how there's not symptoms present. We need to just stick to what we understand about the virus and the illness. That would be a little bit my response.
Also, the virus has an incubation period. So this is the time when there are no symptoms that are present. And the incubation period is between 5 to 6 days. So on average, around day 7, an individual will start developing symptoms. But the individual may be shedding virus in the respiratory tract for 1 to 2 days prior to that. Now, we'll go into how the virus is transmitted, and then we can look at the implications of that. But it's just important to bear in mind that with these mild symptoms, we cannot completely exclude individuals. So we have to also have a very high index of suspicion for, firstly, their travel history, and then secondly, whether they did in fact have contact with a COVID case, because we have to contextualize this within the framework of travel.
Okay, so let me ask you another question. Who can summarize for me what they think the kind of pattern of clinical severity is with COVID-19? So if somebody in the public was to come up and ask you as a doctor, how severe is this new disease, COVID-19? How would you tell them in simple terms? Anybody want to have a go? So, I mean, one question everybody's asking is, are we all going to die from it? So does everybody who gets it die? No. No. Okay. Does anybody who gets it die?
Yes.
Okay. So we've got some information.
I would just tell them it's a new kind of flu or a different kind of flu that's out, and you need to still take care of your same precautions and things like that.
Okay.
Yeah.
So would you say the the pattern of severity is very similar to flu then, in terms of the proportion of people that will get severe illness and die, or a little bit different, or not sure?
I have to say I'm a physio by profession, so I would say I'm not sure.
Okay, that's always a safe answer. Okay, anyone else? So, in simple terms, and again, one caveat we should say at the beginning of all of these presentations is our understanding is changing day by day. And our understanding is also changing because a lot of the data we have to understand this illness and the virus is from the early phase of the epidemic from China. And as we get more information from other countries, some of our understanding is changing, some of what we're seeing is different. But this is kind of a rough guide, and this is what I'm kind of using when people ask me to describe the severity of this illness, is that I say that about 4 in 5 people who get this infection will have a mild illness or be asymptomatic and will recover fully, okay? But about 1 in 5 people will have a more severe illness, and that means a more severe pneumonia that might require hospital care for actual clinical care, not just for isolation. And about 6% will have a critical illness that might require intensive care support. And that's a little bit, as I say, different in different places. In Italy, they're seeing very severe disease and finding a higher proportion that are critically ill. So about over 10% of the cases they're seeing are needing ICU care. So, as I say, this is a kind of rough guide, but just a way that you can put into simple figures for people, that about 1 in 5 people who have it will have a more severe illness.
So epidemiologically, can you explain some of the reasons why you might see the variations?
So I guess the simplest explanation would be the population that's getting infected and the age profile, the comorbidity profile of the population. So in Italy, it may be that there's a more elderly population who's getting infected in this first wave with more comorbid conditions. Of course, with all infections, there may be human genetic factors in how we handle the virus, how our immune response is activated, and it may be issues of the health system, of how quickly cases are detected and before they get severe. So there's probably a number of explanations. Exactly. And so places like Singapore and South Korea, where they've really ramped up the testing on a big scale, will be seeing more of the mild and asymptomatic cases because they're testing many more people. Same in the UK, they're testing large numbers of people, so they're picking up cases earlier. The United States, you might have seen, particularly Washington State, Seattle, they're picking up a lot of deaths before anything else because they're not testing anybody, because they had faulty kits, they have a bad public health system, they have a very centralized system, so they're only catching up with testing now. And you're going to see in the next couple of weeks in the US, the epidemic's going to really skyrocket as they start testing.
You left out one bar. How big is the bar of deaths?
So I think it's on the next slide, but let's just look. It's on the next slide, but one. What do you think? Where would you put it? 1%? And where do you get that 1% from? I'm sorry. Intuition. Yeah. Has it been higher in some places, or is it being reported as higher?
It's been reported as higher. But I don't know, this mild illness or asymptomatic, did you really test everybody that's ever had COVID virus? I mean, that line might be 3 times as long, and the severe disease might only be 2% and critical illness only 1%. We don't know.
Yeah, so that's exactly it, isn't it? It depends on who you're testing. And in most places, the testing has still been in people who present for testing, who present unwell. Once we start to get antibody tests rolled out, we'll get an understanding of how much asymptomatic infection there truly is. And that's happening now. They have antibody assays, and again, places like Singapore are rolling out antibody testing in the population to really start to get an understanding of how far this extends and how far that bit shrinks of your overall proportion. This is just a rough guide to the kind of age profile, and again, this is based on data from China. There seemed to be a slight preponderance of males, but again, there may be cultural reasons, there may be other reasons for that, there may be more smoking, more comorbidities, but the mean age was relatively old. So far, there hasn't been much evidence of children with infection, but do you think that means children are not getting infected? Or what would be your understanding? Any pediatricians in the room?
If they are getting infected, probably being a little bit asymptomatic with less severe disease, and hence not...
And does that surprise you if we're saying this is a bit like influenza?
No. Obviously, like the adults, I think if there's any comorbidity, then they'll present more sick, and then we'll look at that. So, yeah.
Okay. Yeah. So the answer is we don't really know, but for the past few weeks, it's certainly been noticed that there are few children presenting unwell with it. So it was thought maybe the children aren't getting infected. But there's a study just released a couple of days ago where they did intensive contact tracing from a group of index patients, traced and tested all the contacts, and found that actually the children were just as likely as the adults to be infected, but they were much less likely to be symptomatic and to develop clinical illness. So that's one study, but it seems that that's more convincing evidence that they are getting infected, they're just not getting unwell with it. And one critical question then is to understand to what extent they're contributing to transmission of the virus in the population.
One of the possibilities could be that, because remember, disease is not only caused by the virus itself, it's caused by the immune system's response to the virus. So it could be that the immune system of the children is not as robust, or it doesn't mount such a significant immune response, because one of the drivers of these, it's called a cytokine storm. That's responsible for the fever and some of the other features that you see with these diseases. So in a younger population, it just could be that they don't have as robust an immune response, so you do not see that fever as much because of that immune response not being as significant as in adults.
Do you think, does that have any broader relevance to us and our setting here? Is there any other group of people that we're particularly interested in understanding how this infection might affect them? You're smiling, which suggests you're about to answer, but then, yeah. So we don't know anything about how HIV will affect this infection and the presentation of the infection, but we're obviously hypothesizing that it could potentially make things worse. It could potentially cause a less severe illness. We just don't know, and there's no data there yet to help us understand that. So it will be one of the things we're looking out for here.
Get much of this virus in the blood? Is it predominantly in the respiratory tract?
Not thought to be a viremia, no. This is coming to thinking about the risk of death and the case fatality rates that are being reported from this. If we think of an overall rate, what the World Health Organization is reporting on a day-by-day basis is what's called a simple crude fatality rate. And all that means is that they take the number of deaths reported and divide it by the number of confirmed cases on that same day, okay? And at the moment, that's still sitting around 3% then, a case fatality rate. Sorry, 3.4%, yeah? The problem with that is that your denominator there is the number of confirmed cases at that time, but it's not the number of cases that you have a known outcome for. So most of those will recover, okay? Some of them may die, but it's a kind of crude estimate. And when you look at some places, so particularly South Korea again, the mortality there is under 1%. And again, that's thought to be because their public health practices and their clinical systems are very strong, that they're detecting cases earlier, they're managing them well in their system. But the key thing that we want to try and get people to understand here, because there's been a lot of debate about this, there's been a lot of misinformation from important, influential people about how this compares to seasonal influenza, okay? And somebody very influential on the news a couple of days ago, or yesterday was it, told the nation that this is much less severe than seasonal influenza, because seasonal influenza kills 50% of people who get it. Okay? No, apparently it did say 50. That's what the nurses this morning said. I gave him the benefit of the doubt, saying it must have been 15, but they said, no, it was 50, he said. So I don't know who had briefed him before that interview, but it clearly wasn't anybody with any medical background. So you'll know the mortality from seasonal influenza is difficult to know for sure, because most influenza we don't diagnose specifically, okay? And most doesn't come to healthcare. But the best estimates say that seasonal influenza case fatality rate is less than 0.1%. Yeah, so less than 1 in 1,000. So even if we're dealing with 1%, whether it's 1%, 2%, 3%, it's several-fold higher than seasonal influenza. And if you take away anything from this, it's that we are not panicking unnecessarily about this infectious disease. The combination of how easily it spreads and the mortality associated with it means that this is going to be a very significant pandemic. Okay? This graph is really just to show that the case fatality rate varies quite markedly by age. So by the time you get above 80, about 1 in 6 people or so, 1 in 7 people will die from the illness. And you've probably heard that as well as age, the death is really associated with chronic comorbidities, chronic lung disease, chronic heart disease, diabetes. And again, we don't know whether HIV comes into that or not. Lily, help us understand a bit about how the virus is spread.
Okay, so this virus is spread via respiratory droplets. So droplets, as opposed to being aerosolized or airborne, droplets are heavy. They fall only within up to 2 meters of the individual who is busy sneezing or coughing. All right, so that one needs to bear that in mind. It doesn't get aerosolized. It is not suspended in the air. It is not traveling long distances. It is literally within the proximity of the individual who is expelling those droplets. The virus itself, so whoever is within that 2 meter radius, or whatever is within that 2 meter radius, can become contaminated with those droplets. So if you've got a tissue, if that individual has sneezed into a tissue, that tissue is now called a fomite. It becomes an infectious material. So when we refer to fomites, it refers to non-human, I should say, or inanimate surfaces where you've got these droplets sitting. So a fomite can be a pen, it can be your cell phone, it can be a tissue. So that's what we refer to as fomites. So an individual who is within the proximity of that, if that individual is there, then they can actually acquire the infection because of that radius. The other important thing to consider is that even though the virus is detected in the stool, it is because of shedding. It is not because it can be, it's not transmitted. As far as we know now, it's not transmitted through that way. So it sheds in the respiratory epithelium, it is suspended, it is expelled through the droplets, and then whatever is in contact with the droplets then becomes infected. It can sit on surfaces. Studies say that it can sit on surfaces for up to 9 days. So if surfaces are cleaned, bear in mind, it will not be sitting there. So it is important, that is why we say that it is very important to sterilize, keep the surfaces clean. Also, when doctors are going from patient to patient, to ensure that your stethoscopes are wiped with disinfectant.
Which I'm sure everyone does anyway.
Yeah. Do you have a question? Possibly, yes, because you are expelling, I mean, as you're coughing, there is potential for droplets to come out. Even with sneezing, there is potential. Chest physio is a potential way to produce these droplets as well in an individual. So it's important for healthcare workers to take the appropriate measures of protection. Now, why do people wear masks? The masks are not per se for the healthcare workers. In our setting, we would need to wear if we are, like I said, if you're doing chest physio, if you are examining these patients, if the patient is in isolation. But in the general public, we'd advise the individual to wear the mask. Why? Because we want to stop them from expelling those droplets to everyone else. Okay, so that is the purpose of the mask. For you, you'd probably be wearing the mask because you want to avoid touching your mouth and your nose. Because remember, the droplets, once they are expelled, if they are expelled and they get into your eyes, your nose, or your mouth, that is the mucous membranes, then you have the potential. And remember, even after they get in, remember there's the mucus that it has to then try and break through that barrier. Then your immune system mounts a response. Plus, it has to meet a cell which has the receptor and then enter the cell. So that is the reason why many people, we said 80%, have mild infection, because your immune system is able to mount a robust response at some point to overcome this. Okay? And then also, if you touch a surface, do not touch your hands, touch your face, your eyes, or your eyes, your nose, your mouth, without washing your hands. So even if you wash your hands using regular soap or water, it is fine. Soap does not have to be Protex or Dettol. It is a regular soap with regular hand washing for at least 20 seconds, the way doctors wash their hands. You've seen how doctors wash their hands in theater as well. That is all that is needed to actually get rid of this virus. Okay?
So we keep joking when we're doing this that you can see us both
Trying not to
standing
touch
here
our
either
faces.
like this or like this, because we know that
I
if
tried
we
not to
stand
touch
here
my face.
naturally, we're going to be touching our face all the time as we're telling you not to do it. So, Lily, it's still you to tell them a little bit about when the virus is transmitted, thinking about the spread of disease again.
Okay.
So
I think I mentioned this a little bit
you
before.
can transmit.
Can you explain the problem with the mask in terms of how the mask they can transmit?
Yes. So with the mask, remember, if the individual is, or even if you have a mask on, but you do not know how to use the mask properly, you're not used to it. Remember, the mask is containing whatever bacterial viral load that is there, and you are then, if you keep adjusting it or touching it, you actually you end up self-inoculating. That's the one thing. Then the mask, there are different types. There's the normal surgical mask, and then there's the N95 mask. The N95 mask actually serves as a filter, so it filters whatever comes in. So we don't put that on the patient, okay? Because we don't need them to be filtering anything, okay? We can put a surgical mask on the patient. The N95 mask is specifically for individuals who are exposed to more high-risk procedures, like I said, the chest physio, where you are inducing sputum, or in the ICU setting where the individual is already isolated, or those kind of settings. So it's not generally for everyone, including the cleaner, unless that cleaner is specifically allocated to that isolation ward. Okay? Yes.
Just for clarity, you said that the virus has like 9-day lifespan on the surface, up to a 9. So, is that lifespan different? Like I'm saying, if somebody's infected and they're coughing and sneezing and they're coughing on their own hands and stuff. I know it sounds not the best thing to say, but then how long is it? What's the lifespan, like on human tissue or human? Is it the same?
In essence, basically. But one would expect that it would be less on humans because we assume that surfaces we are washing more frequently. We're just speaking about in general, when they've done these studies and they've not decontaminated a surface, they found for up to 9 days they could still pick up the virus. But remember, the virus has to meet a cell in order to become activated. It's present there, but then it has to meet a cell in order to replicate. Yes?
We also heard that it dies, though, at the temperature of 24 degrees. Is that correct?
Well, our textbooks say 56. Yes. But, I mean, in a way, we are actually... you wanted to say something? Okay. In a way, direct sunlight, that in itself also, because of the heat, it would inactivate the virus. So those kind of things we have to bear in mind.
Yeah, and I mean, it's thought that in the temperatures that we have at the moment, that makes a big difference to the lifespan of how long it's going to sit around. So and the important thing is the 9 days is so it's not based on this virus, it's based on other coronaviruses, and the 9 days is the extreme. Okay, the average is probably a few hours. Okay, so, but we're just giving a kind of extreme example to say these can sit around for some period of time. But heat definitely affects it, and that's one of the theories why we've not seen more infections in warmer climates yet, and one of the warnings that it may change as we move into winter. Humidity also affects it, and the more humid, the longer these droplets will sit around. So we're in a bad situation there.
I think the message we're trying to convey is that you need to clean surfaces. So you need to be cognizant of the fact that the virus can last a while, but you shouldn't say that because now this is more than 9 days have passed and somebody has been in this room, there's no need to clean the surface. Just be vigilant about cleaning surfaces.
Sorry, I heard the lady mentioning something about the use of the N95 masks. So can you clarify that, because I was sitting on the passage, I couldn't hear that. So you're saying it filters the air coming in. So are we wrong in using the N95 mask?
What does the N95 mean? We use this term all the time, N95. What does it mean? What does the N95 refer to? Percentage of what?
It's the percentage of microorganisms that are filtered. Yeah.
Percentage of microorganisms filtered. Okay. Anyone? Any other suggestions? So you're right. It's a percentage, but it's a percentage of particles of a certain size. So what they test is particles less than 0.3 microns in size, so micrometers, yeah? And the N95 mask will filter 95% of those particles, okay? And there are other standards, but that's just to give you to understand what N95 masks are, and that you get N99 masks and FFP3 masks, which have a higher standard that filter more of the particles.
When do we use them? They want you to repeat that.
I see. When do we use them? So the guidance at the moment here is still that we should be using them when we're dealing with a suspected case or a confirmed case. Okay. But one of the issues is whether we are using them properly. So hands up if you have been fit tested for a respirator, N95 or FFP3. So nobody's ever been fit tested for a mask. So you don't know whether the mask is doing the job that it's supposed to do, essentially. Yeah. So that's a big problem that we have, that we have these masks, but we don't use them properly and test them properly.
And I think for me, one of the concerns that I have is when people put on masks and then touch the mask, right? Because then it defeats the purpose. You put on the mask and then just watch people how they took off the mask. They grab them somehow in front and then they throw them away. But now you've been walking around and people have been kind of coughing or sneezing, and that mask outside has got all these organisms, and now you're touching them. It sounds like something small, but it's important when we think about the purpose of using masks and the importance of breaking transmission, that even when you take them off properly. Think about in the same way you don't want to touch your face, you don't want to touch the mask. And also then we just need to make sure that when we are explaining this to patients and how to use the masks, that we are careful that we explain them properly.
So one thing that we need to think about is the opportunity that preparing for this problem gives us. And one opportunity is that we develop stronger systems with occupational health colleagues that we are actually doing proper fit testing for N95 masks, because it's not just relevant to this, but it's relevant to TB, and it's relevant to influenza, and it's relevant to the next respiratory virus pandemic that hits us. And it's not all that complicated to do. It's a bit of a faff, but it's not all that complicated to set up the systems.
How much easier does this virus spread than the normal flu virus?
So good question. And I think we're settling at a kind of situation where we say that the transmission potential is quite similar to seasonal influenza. So initially we were thinking that the transmission seems that it's driven primarily by symptomatic individuals, okay? Flu spreads easily because quite a lot of transmission is from asymptomatic individuals in the day or two before they become symptomatic. That's why influenza spreads very easily. And there's now some evidence from modeling studies and things that there may well be some contribution with this virus as well, that there's some transmission in the pre-symptomatic stage. We know that the virus is detectable 1 to 2 days before the symptoms start, so it would make sense that there could be some transmission there. We just don't know how much that's contributing to the overall spread. But I think, I mean, as a general answer, we think that it's broadly going to be quite similar to influenza. So the difference with influenza is really the severity and the mortality. So when you combine the transmissibility of it with that clinical severity, you end up with a much more severe pandemic. Does that kind of answer, or?
Yes, thank you very much. I've always wondered, since this is transmitted so easily, what are the chances realistically of us actually stopping the spread in South Africa? I mean, I can think that in some first world countries, maybe they're reasonably good at it. But I mean, if even America is failing and they've spent trillions on their health care system, why is South Africa even trying to stop it if it's going to be spreading everywhere in any case? No, I mean, seriously.
I'm going to ask Eunice to respond because he has similar thoughts.
But I'm not the right person to respond, because I also believe that the horse has bolted, and we're trying very hard to shut the doors after the horse has bolted. So I have a suspicion that we will not be able to control this. But what Richard was explaining to me in the car made a lot of sense. All we are really doing is trying to delay the progression of spread. Because if we do that, we will...
I didn't say that.
Oh, okay. I'll let Richard tell me again what he said in the car.
No. So I'll put it back to you, but I said that that's where some places are now doing. So the UK and other countries have got past that containment phase. There's no point trying to contain it. Their point is to delay it, so that you delay it till summer when the hospitals are less stressed. You delay it to give time to get your systems up and running. I think we can still, we should be still aiming for containment. I will be as pessimistic as you guys about how successful we will be at that, but we should be trying to do that at this stage.
All I can say is time will tell. No. I honestly believe that we are going to get, SARS is going to become as endemic as influenza is. COVID. It's going to become as endemic as influenza is, and we're all going to have a patient coming in where we would screen as we do for influenza and other viruses, and this is going to just become another virus in the panel that we're going to be checking out. But I guess time will tell. I don't believe we can really stem this virus, but we will only know over time.
So I definitely agree with that, but that's a slightly separate point. Because the first issue is what is the scale of this first wave of the pandemic going to be in each country? And I think we are seeing clearly that you can make a difference if your systems are strong. And I think I don't disagree with the two of you that our systems are not strong enough to do what Singapore and South Korea are doing, or the UK.
Hi. In terms of systems, we're talking about very big things, and I think our cleaners and our security guards are actually the heroes in this here. And I don't think they really understand their role in infection control and the fact that this is a fomite-driven spread. So in hospital over the weekend, I was sort of experimenting a bit with myself and seeing, well, where do you touch? What do you actually do? And it's actually quite frightening. The cleaners actually, there was no soap in the bathroom, and I said, can I please have some soap? And she said to me, I don't know where to get it, you know, and there was sort of that attitude, and I think we really need to strengthen the training of cleaners and that they are actually at the forefront of this, and then visitors coming into the hospital via security guards actually need to be the guys that tell them about hand washing and tell them about here's some alcohol spray, all those things, and then maybe we can contain it to a degree at this stage.
I couldn't agree more. The basic principles that we often forget because we want to start thinking about the high-tech solutions and the complicated stuff, but we forget the fact that there's not soap on the ward and things. Did you want to say something? No? Okay. Four more cases in KZN? From the group. Okay. Lily, okay, that's good timing. So how are these cases being diagnosed? And why are they taking so long to diagnose?
Okay. So the tests, the specimens, obviously, because we are saying this is a respiratory-driven virus, so the tests and the specimens that we need to collect would be the specimens from the respiratory tract. So that would be either an oropharyngeal or nasopharyngeal swab, or if a patient is coughing and has a productive cough, sputum. And this goes into a special viral transport medium, which maintains the integrity of the cell which contains the virus, so maintains the viability of the virus. So that's why it goes in special transport medium. Currently, there's only one laboratory in the whole of South Africa that is testing. It's the National Institute for Communicable Diseases, the NICD lab that's in Johannesburg. So from the time that they receive the specimen, not from the time it's taken, the turnaround time is estimated to be about 24 hours. But one needs to bear in mind that as the cases increase, they're going to be inundated with specimens, especially from suspected cases. And they did inform the rest of the laboratories that at a specific time point, they will decentralize to the other laboratories. So all the other laboratories which have virology services are now preparing and getting kits and doing validations to ensure that they will be able to maintain this turnaround time for these specimens. The test that is being done is a molecular test which is highly sensitive and specific. It tests for the virus itself. It does not test for antibody, tests for the virus itself. So it looks for the specific RNA that is related to SARS-CoV-2, and it picks this up within the sputum. So PCR is the test that we are doing. PCR is it's a type of amplification test. So so we are performing the most, the best test available. Although the NICD does speak about blood tests as well. Remember, blood tests are or serological tests for antibody response to the virus, doesn't test for the virus itself. So the gold standard is, in fact, respiratory specimens.
Any questions about the testing and the testing capacity? Who
does the swabs?
Okay. The swabs, so I would think that the oropharyngeal swab can be done by a nurse, but the nasopharyngeal swab may require more guidance, so I would think a doctor would be able to do it. videos of the swabs of the
Well,
specimen
I'm just thinking
collection.
of myself. I've never taken a nasal swab. I wouldn't know how to do it. Probably these guys are more
Has
trained.
anyone taken an oropharyngeal or nasopharyngeal swab? No.
It's like most things. It'll be
Okay.
a nurse can't do it, a doctor has to do it, but
Yeah.
you've never been trained in doing it.
Okay, so an oropharyngeal swab is basically a throat swab. So it would mean using a tongue depressor, having good lighting, and perhaps and asking the individual then to open their mouth, put in the tongue depressor, and swab only the tonsils and the back of the posterior pharynx. But you have to be careful not to induce a gag reflex. So that's how a throat swab is done. Okay, then that is put into the viral transport medium, which is in one tube. Then that is closed off, and then the nasopharyngeal swab, you would need to ask the individual to tilt their heads very much back, and they would be sitting down at the time. And then one would insert the swab. It's a very small swab, directly parallel. It would be very, very straight to the back until you feel resistance, and then rotate it. Then put the same swab into the same single tube of viral transport medium to increase the viral load yield. And then seal that off. There are two special forms that need to go across with these swabs. The one form is called the specimen submission form, available on the NICD website. The second one is called the patient case investigation form, which has the patient's details, all those things that you need to fill out, plus a contact tracing form attached to that. So there's those two forms that need to go. Prior to doing all of the specimen collection, remember it's being done at NICD. You would need to phone NICD hotline. There are two numbers. They gatekeep their tests. So there must be, the cases must be discussed with them, and when they do confirm that this is could be a possible case, they would tell you, okay, go ahead and take the specimens. So that is important. The viral transport medium can be acquired from the laboratory. The swabs as well. Okay.
We don't have slides on this, but how are we going to manage a case? When we start to see cases, what is the management of COVID-19? Are there any treatments, or how are we going to manage the condition? Eunice?
I had a question before that. The patients who died, what was the main reason for dying? Was it respiratory failure? Do you have any idea?
Good question. I mean, certainly the pathology that's associated with the very critical illness is ARDS. I mean, that's what the kind of pathology leading to the critical care admissions and things is. But whether that's always the case in the older people that are dying, or some of them are dying with a less severe lung injury, I don't know. But certainly the common complication is ARDS, and then there's also the usual shock and myocardial injury and things. Kind of multi-system failure and things hasn't been well reported, but of course if people are in ICU they'll develop that for other reasons. But yeah, I can't give you a clear answer, but the ARDS is the main kind of progression of the lung disease.
So how are the bodies handled of deceased individuals?
Good question, and I don't know the answer to it. How do we deal with a dead body? What are the precautions required? I think that there is something in the national guidelines on that, possibly in one of the appendices. We'll have to look and get back to you. My guess is that it would be standard precautions, because this is not Ebola. It's not that there's virus all over the body or anything. It should be localized to the respiratory tract. So I'm not sure there would be anything special, but we can find out. Management. Yeah, symptomatic management, isn't it? There is no treatment for this virus at the moment. Has anyone heard of possible treatments that are being tested?
There's talk of 2 antiretrovirals, which might be, but if I was a company, I would start that rumor as well to get more sales.
Do you know which ARVs specifically? It's the protease inhibitors and lopinavir, ritonavir. There was some evidence that it was active against MERS. It was in a clinical trial in MERS and against the original SARS. But from what I've read, people who really know coronaviruses, they say these drugs are quite weakly active against it, and they don't expect a good clinical effect. But there are other antivirals that have been developed with broad anti-coronavirus effect that look more promising. The drugs called remdesivir and things. So when I last looked, there's over 200 clinical trials on the go in China. Whether they've been able to recruit the participants they need because the epidemic's slowing down there, I don't know. But we should start to get some data about treatments that may work. But in the meantime, it's just the same as we would manage any viral respiratory illness. Sorry, yeah, chloroquine is another drug that has some in vitro evidence behind it, and there's lots of trials going on. There was some press release last week or the week before from China saying that they were seeing that this was effective, but I couldn't understand how they could be saying that, because these are randomized controlled trials they're doing. So unless they've unblinded the data as they're going, which they shouldn't be doing, then they shouldn't know whether it's effective or not. So I think we're waiting to see the actual data from these trials, but it's potentially promising. Let's just finish with a couple of slides just to bring us right up to speed on where the epidemic is really. There are now over 100 countries affected and over 100,000 confirmed cases, more than 3,000 deaths. And in Africa, there are nine countries affected and now 7 confirmed cases. So you can see with these presentations, we have to update on a daily basis. This is just a slide showing from the very beginning of the epidemic in December, the overall epidemic curve, and the blue is the cases in China, the orange is the cases elsewhere, and you can see that China has managed to really slow the epidemic down, and they are now reporting fewer than 100 cases each day. When at its peak, they were reporting several thousand each day. So the epidemic has really come under control there, but it's really now taking off in other parts of the world, as you'll know. This was just a big spike because they changed the definition of what a confirmed case was. This is showing the growth and showing that the 2 main areas, this orange and this purple, is kind of Europe and the Middle East and Iran, and that's where the kind of most rapid growth is at the moment. And this is just showing some selected countries and just showing, so the x-axis here is the days since the first case was reported in the country and the total number of cases on a logarithmic scale, and just showing how the growth of the epidemic has been slightly different in different places. So very rapid here in Iran. Italy, clearly very concerning now, and the fact that so many of this group that have been in Italy got infected tells you it may be even worse than what's being reported in Italy. We are now at, day 4 from our first reported case, and we're at 7, so we're somewhere in the middle of this kind of pattern, but clearly very early days.
South Korea seemed to have maintained very few cases until about
Yeah, so this is South Korea here, isn't it? But yeah, so I mean they've had very strong systems for early identification and contact tracing. They're the kind of place that's doing this drive-through testing. So instead of going for a burger, you go for a coronavirus test. So you just drive up in your car, open your window, get swabbed. Presumably you give your mobile phone number or something so that they contact you if it's positive. And that's happening in a lot of other places, much more community-based testing. So rather than waiting for people to come to a health facility and spread their infection here, you go to their home to test them. Clearly, again, we're not going to have the capacity to be doing that at any scale in South Africa, but we do need to think of more creative solutions for when things start to get worse and when we need to really ramp up the testing. I think that we are going to stop there and encourage some more discussion. I'll maybe put this up just as a placeholder to start that discussion. As this is the current kind of criteria for who should be tested for the coronavirus, and it would be interesting to hear people's thoughts about this and to just generally open up discussion for questions and thoughts.
Yeah, so I just want to mention a couple of things. I know that some people think that, it is overwhelming to try and mount a response to COVID-19. But for those of us in public health, we know that it is important to do. It is necessary that we come up with a plan, we put a plan in place in order to make sure that we manage the population level response. There is an individual kind of response where you have a suspected case that one needs to diagnose and isolate and treat and so forth. There is a step before that where you might screen, you've got potential contact, potential exposure, where you're on a quarantine and all of that. Those things we need to be clear about and know what to do. But even before that, the fact that it will be difficult to do doesn't mean that we shouldn't try to break transmission as much as possible. And so for us, we've learned lessons, and the way we are sort of organizing ourselves in our team is that you've got people who are thinking mostly around the sort of clinical virology aspect as well as the clinical symptoms and diagnosis and treatment aspects. And that is more of the clinical response that we have to articulate and the protocols around that. How do we activate what at what point? Including the fact that even our clinicians and health workers have to have a high index of suspicion to be able to pick up a case. Now, that, of course, depends on issues of surveillance as well, being able to track where cases are, where they are moving, so that we are able to alert people and they know that, okay, we might have potential cases here. Others we may not necessarily anticipate, especially of people who travel, who may present to any health facility, but it requires awareness and alertness to be able to respond. On the population side and the public health side, we do need to think about issues of prevention, issues of education, issues of behavior change, and so forth. We do think of our response, our general response, in terms of 4 levels. In terms of the first level, and this is adapted from the approach that Singapore uses. The first level being when you don't necessarily have a case yet and you are green. So a lot of the things that you do there are mostly preparation, training, awareness, and just preparedness. Once you have a case, but it is an isolated case, the cases that we are having in South Africa at the moment are isolated cases at the moment. So we move to level 2 of response. And at level 2 of response, yes, you have to manage the cases that you have, but you also need to make sure that you trace all possible contacts. And again, make sure that people are screened, they are quarantined if they are suspects and so forth. And again, think actively about how do you prevent or minimize the potential for community transmission. Level 3, it's when you start to have community transmission. And so at that level, you've got people who would present with symptoms and meet the case definition of COVID-19. They may be diagnosed as well and with COVID-19, but they don't have any known contacts, known travel, known exposures. Somehow they got it somewhere, we don't know where. So at that time, you start to make an assumption that you are having circulation of the virus. And so then that goes up to level 3. And you might find that it is circulating in certain areas, not everywhere at that time. So the effort would be to try and contain it in those areas. The 4th level is when you start to have more widespread transmission and circulation of the virus. You've got a lot of cases that are emerging in different places. And at that time, then the response becomes very aggressive. You know, when you are in level 3, you can think of partial closure of certain buildings or institutions, depending on the context in which the virus is circulating. But you don't necessarily have to shut down borders and things like that. But when you are at level 4, then you can use more aggressive measures, including closing down schools, closing down campuses, closing down institutions, and so forth, and kind of leaving mostly the essential institutions to function. So we would use more aggressive measures at that time. And I think that's what at the moment we are saying, yes, we are at level 2. As much as we can, we need to remain with this sort of localized, isolated cases. And isolated cases would be the people themselves who have been exposed during travel, as well as their contacts, their close contacts. So those that they have been traced and their contacts will remain sort of more isolated cases. But the moment we start to have more general spread, then we need to up our response. My concern is that generally what we tend to do is to be a step behind. We spend a lot of time in the phase of denial and kind of waiting and hoping that it doesn't happen. We don't prepare adequately. When you are clear about your levels of response, you know that you want to hit that level of preparedness before you get to that level. So if you are going to go to level 2, you want to make sure that you've got systems in place for a level 2 response before you get to level 2. But what we tend to do is have a catch-up. We get to level 2 first, then we start to respond. And then we're going to get to level 3, then we start to respond. At that time, it is not efficient to work like that. Countries that are very good at responding to this kind of epidemics like Singapore have systems in place. And it's almost like the systems go on automatically. They are there. When they tell you that at level 2, we start to make sure that we've got hand sanitation everywhere. And when you arrive and they're at level 2, that's what you will find. In their institutions, we're not going to have a situation where we're walking into a meeting like this and there are no sanitizers or some sort of enforced processes to make sure that we are sanitizing. We are already level 2. Yes, we may not necessarily have been exposed, but we are already level 2. If you are now at level 3, and they are saying that they have to screen for temperatures, which is what they do when they get to level 3 in terms of buildings and entrances, that's what they will activate. And the same day that they had activated it, you could see it already, they were monitoring temperatures. But what's going to happen in our case is that we're going to be scrambling already when we are having a case. And this is why, for me, it bothers me so much, this sort of coping by denial, where we constantly hope that it's not going to happen, it's not going to happen. And then it catches and we are not ready. Okay, and the other thing that is important is you have to understand, to mount an effective response, you need people with different sets of skills. There's a reason why our response team is multidisciplinary. You need people who come from different disciplines, but then all of those responses, be it epidemiological in terms of surveillance and tracing, or in terms of public health, or in terms of infectious disease and virology, you need to make sure that you are adequately equipped to respond. So in my view, every institution at this point needs to have a team that is basically working on its preparedness and making sure that there are measures that are put in place everywhere. And not just health institutions. I'm talking about all social institutions. And that is on top of having to make sure that all households are also being prepared to be able to cope with the different levels. When we started the response team at UKZN, the idea was that we wanted to build a response team that can help us prepare before a case occurred in the country. And just 2 days later or 3 days later, then we had a case. So right now, I think that we are kind of coming out of that panic mode that we had after we found out, but we do need to make sure that we have a rational approach to this response. So let me hear if you've got any other questions, concerns, suggestions, things that you would like to raise with us.
I was just saying that, as healthcare workers and all of us, it's very essential that we protect ourselves by ensuring that we wash our hands, that we follow those measures. And also, if we have individuals who are coming in coughing or whatever it is, hand them a mask, and then after that continue with your assessment of them. If you are collecting oropharyngeal or nasopharyngeal swabs, please ensure that you have a visor, that you have a mask, that you have gloves, and possibly a disposable apron. I know the facilities don't always have N95 masks. The least you can do is put on a surgical mask. We have to work with what we have. That is important. But in your case, with chest physio, it is essential that you have a fit test done as soon as possible and have an N95 mask if you are conducting chest physiotherapy. Okay, so those are important things just to bear in mind. Because remember, we've learned from all the other epidemics and outbreaks, and honestly, healthcare workers are the ones that fall. Many healthcare workers, and that's purely because of not taking the right measures. Yes, they may have had the first inoculum and all of that, but very often healthcare workers get infected because they are not taking the correct measures, and we don't want that. We don't want to see healthcare workers going there, risking their lives, and then at the outset you're having a problem just because you didn't take the right measures. So that's why we are saying from the beginning, ensure that you practice safe measures in terms of infection prevention and control. Thank you.
Yes, sir.
Okay. In a busy hospital, in the casualty setup, the patient comes, then the patient is a suspect. So the doctor has taken the swab, everything. So now is the doctor allowed to continue with the next patient, or doctor should be separated?
You want to answer that?
So here we're assuming that the person has been identified as a person under investigation and that you've taken the correct precautions. So you've put on your PPE correctly, you've doffed the PPE correctly, and then yes, if you've done that and you've washed your hands again afterwards, there's no reason you can't continue your normal work. So it's all about how well we're doing the donning and the doffing of the PPE. So again, we asked you how many people have been fit tested, how many people have actually been properly trained in donning and doffing PPE. Anybody? No. You have? In terms of kind of full PPE, gown and gloves and mask and visors?
No, I remember the infection control nurses did the N95 for us, about fitment around the nose, flush against your cheeks. Yeah.
No, that's not a fit test. That's just a seal.
For rehab.
Check.
Okay, so it was a seal test.
So that's just checking that it's a reasonable seal on your face. But a fit test is where you put this funny hood on, yeah, and then they spray something in and see whether you smell, taste it, because that tells you whether it's filtering properly and fitting. So you're just talking about a check of the seal. So it sounds to me like this is a priority, actually, to get our infection control teams on board to really be properly training and getting people up to speed on PPE and protection. Because as Lily said, this is our health that we're worried about, and it sometimes does seem trivial, and it's one of those things, why do I need to be trained on putting on a gown and gloves? I mean, it's obvious how you put it on, isn't it? But it's not, and we do it wrong. And it's been shown over and over again that we do it wrong, that we contaminate ourselves. And I just speak from experience. I'm from the UK, as you probably noticed. I did my training there, and we had very rigorous systems for training and being properly signed off that you can don and doff the PPE correctly, and you're able to see people that are suspected of. In that time, it was the avian flu outbreak and things. So places do take it seriously. I think we don't. And to me, that's just a bit crazy when we think about the threats we're exposed to with TB and drug-resistant TB, that we don't do this properly. And I think we need to push at facilities to strengthen that.
Now, but I think that it is a priority, so it's important for your IPC sister to show you all how to do that. Okay.
Do we think the IPC team know how to don and doff PPE?
So the IPC team actually recently had a demonstration and a talk at the lecture theatre, and they went through the whole process, practically showing us the donning and the doffing and everything. Okay. Yeah.
Okay, and did you find that helpful? Yeah. Okay, and are they then doing it with individuals as a follow-up to check that you're doing it properly? In those areas. Okay, obviously that's the priority. The other place, like everything, the other place to look if you don't know and you want to look is online. If you go on YouTube and look up Public Health England, they have excellent videos, one on donning, one on doffing the PPE, and it just takes you through the process to follow. Was there a question here?
I just have like a personal question just with kids going to schools, because I think schools and departments of education is maybe one step behind us because we are health practitioners. So when like teachers are saying don't send your kids if they've got a runny nose or coughing, they're not overreacting, or they're overreacting? No.
So we're talking generally here about respiratory illnesses. Yeah. Yeah.
They usually use fever as a benchmark.
Okay.
So from what I heard in terms of schools, they would say, okay, you know, in the past, if a child has a fever, do not send the child to school. If the child has diarrhea, do not send the child to school, or has any other significant features. If the child has a runny nose, it's acceptable. But then now we have to bear in mind this whole history and then the contact. So if the child has had exposure, we have to ask these extra questions, which is very important. So yes, we may take the other precautions, but now we have to add in the whole question of travel history. The other, I remember the other thing that the schools would do would say, like, okay, if a child has completed half the course of the antibiotics, you can send the child back to school. But now, like I said, again, we must just bear in mind the travel history.
My concern is that in general, we don't have a culture of taking respiratory illnesses seriously. We don't have that. So, I mean, how many of us, when you've got like common cold or flu, you actually stay home? We still go to work, and we still sneeze, and we still cough around, and we still infect everybody. We've got more a culture of having to work no matter what. So which is why we also can't tolerate it that a kid is not going to school. And it's inconvenient for us as adults as well when a kid doesn't go to school. But in general, we don't really have a culture of staying home when you are unwell. And to be honest, even employers don't quite tolerate it. We don't have a culture of employers also tolerating people working from home or staying home. But I think that it is something that we have to truly reflect on. And I understand that at the same time, we don't necessarily want to compromise productivity to a point where, we're all just sitting around home and pleading sick all the time, which we can do. But, and there's something about the social contract that kind of, or the social pact around this issue, that right now, as we are preparing for the potential outbreak of COVID-19, we have to come to terms with the fact that learning might happen in different ways. We have to come to terms with the fact that we might have to work at home. Life will continue, but it will continue in different ways. We have to be able to adapt. This is very difficult, but it is a conversation that we need to start having very soon. In the university, we are already starting it. We are already saying that actually, what does this mean? How do we actually entrench a culture of people when you're having symptoms going away? And part of it comes from the fact that we tend to look a lot at individual risk. Yes, I am sick, but I'm feeling okay. I'm sick, but I'm okay. Right? I'm still sneezing, I'm still coughing, but I can walk around, I can work. And in fact, if I were to admit that I'm sick, then especially as a man, is an insult to my masculinity. It means I'm weak, or it means something else, whatever your context is in terms of how you interpret what being sick is. And all of those things then kind of culminate into a situation whereby we are sitting and we are coughing and we are sneezing. And right now we are having a situation where you being sick is a risk to someone else, not just you. So it is putting upon us the responsibility to be able to protect other people, which is also something that we are not quite used to. The notion of taking care in order to protect other people doesn't quite resonate in the way our society is organized and our society functions. But we need to move into that space. I mean, this idea that when I've got a mask in my bag and someone starts sneezing and coughing, it's important for me to give you the mask in order to protect everyone in the room is very difficult. I'm much more likely to take the mask and cover myself instead of giving it to the person to protect everyone. Like, this idea of public good, it's very difficult. But the challenge that we're faced with now is compelling us to really start to think about it. So for me, I think that, yes, you don't want to necessarily stop working because of anything that you sneeze because of dust and you start, panicking, like saying that, oh, I can't go to work. I mean, we don't want to overreact, but at the same time, we don't want to underreact. Yeah. Yes, ma'am.
A lot of people are asking about the flu vaccine and whether or not they should be having it. I don't know the answer for them.
I'm going to ask Lily to answer that.
Okay. So we are heading into flu season. In April, we'll be heading into flu season. It is important to take the flu vaccine. Why? Because you want to reduce your, your comorbidities. And remember, bearing in mind, influenza has the same presentation, virtually the same presentation as COVID-19. Also, if you've taken the flu vaccine, you're reducing your, like we said, the comorbidities, your chances of acquiring these respiratory infections, of panicking, of getting anxious. So it is important, and also by taking the flu vaccine, you are also protecting the other individuals around you, because then they also are not likely to get the flu from you. Because remember, they are elderly. Also, you would encourage the elderly and those with chronic illnesses within your families or within the communities or within the hospital to also take the flu vaccine for the same reasons. Children. Yes, children can also take the flu vaccine. Basically, you can give the flu vaccine from about from about 6 months of age. So, yeah, you can give the flu vaccine as well to kids. Remember, it's inactivated. Even pregnant women can take the flu vaccine.
We're going to have to wrap up, but I think let's just take those 2 questions.
At what point of your stepwise ramping up of containment does stopping elective surgery to make space in hospitals fall? Because I think that is quite an important thing, because a lot of patients will be coming and then, you know, we won't have, especially in overcrowded hospitals where there are quite a few, especially in Pietermaritzburg as we speak, and we need some guidance on that.
So my view, I think, is that your response measures depend on your specific context. And I do think that you need to have a response team that plans for the outbreak, whether it's going to come or not. I think you need to have a plan and know what you're going to do. For me, I think that is really important. And that way, these discussions are going to come. A lot of the planning that we have put together came out of asking these questions. So we've been sitting and looking at what the literature is saying, looking at what's happening elsewhere, and then saying, okay, what do we do about that? What do we do about that? And then looking for solutions and developing a plan. So right now, what we are now discussing is exactly how do we respond to comorbidity, for example. I mean, what do we say to people who are currently smoking? Because we know that that inflammation of the lungs is going to predispose them. What are we saying about all of those things? There are all these things that we haven't really taken a position on, but we're going to have to take a position on. So I think that it is important, even in your case, to say, when you start to have community transmission, what are you going to organize yourselves? When you start to have more widespread transmission, how are you going to organize yourself? Those things are important. And you can take a lot of lessons from other countries, like the extreme measures that Italy is taking at the moment, expanding their ICU capacities. Like it's incredible to see what people are able to do. I mean, China, not many of us are going to build a hospital of 1,000 beds in 10 days like China did. But people are taking extreme measures, which is why I think that every institution should have a plan on how they are going to respond. That's my view. I'll take yours last, just so that we can...
Sorry, mine was just a comment about social contract, and that like various religious or social gatherings, whether we attending church or temple, I mean, those associations, they're also relying on Department of Health to give them some guidelines. Personally, I attend a weekly gathering, and they've actually put up hand sanitizers, and how food or drink is offered to the people from the gathering has also changed. So, I mean, there has been movement from people taking an active stand. So I think we should also support those too.
No, I cannot agree more. I think that it's really, and for me, when we started this sort of campaign, that was my hope. My hope was that people will be sensitized to be able to start to respond. And we understand that even with health promotion, it's one thing knowing what to do. It's other thing actually doing it. So when those kind of things for me are much more encouraging, when people are taking actual steps towards changing behavior, and especially if those can be consistent. We want to make sure that we encourage consistent behavior change.